Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home-related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar is Navigating Opioid Use Disorder in Long-Term Care Facilities, Treatment, Screening, and Education. This is part one of a two-part series. We invite everyone here to join us again next week for part two, which will be next Wednesday at 2 p.m. And now I'd like to introduce our guest today, Dr. Jean Storm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again today.
Thanks so much, Kathy, and thank you everyone for joining me on this beautiful late spring afternoon. So today we're going to be talking about opioid use disorder and treatment, screening, how to kind of go about implementing some policies in your facilities around opioid use disorder. I know this is something that a lot of facilities are really not doing, maybe for just multiple reasons. So we really need to start to be getting comfortable around opioid use disorder and treatment in our facilities. So we're going to be talking about the definition of opioid use disorder, the prevalence. It's really more prevalent than you would have thought. We're going to talk about the risk factors for opioid use disorder, and we're going to talk about some ways to reduce the risks, because if we're not screening our residents for opioid use disorder, we really don't understand what risks they have of developing opioid use disorder. So we really have to understand what risks our residents have of developing opioid use disorder. So we're very cognizant about opioid prescribing in these residents. We also are going to talk about screening tools. I'm going to talk about we're going to start with a case. A 68-year-old female was admitted to the facility after a hospital stay for cholecystitis. She has a history of chronic pain and has been taking oxycodone 10 milligrams every 8 hours as needed at home for several years. She arrives to the facility with orders for oxycodone 5 milligrams every 8 hours as needed and immediately asks for an increase in her dose. So this is an individual who's taking opioids chronically at home, and she had a dose reduction in the hospital by half. The physician denies the request for dose escalation when the resident arrives to the facility. 1 week later, the resident is found unresponsive, apneic, hypoxic. She appeared to have overdosed on an opioid. 911 is called, naloxone is administered, and the resident's condition improves. After the resident is taken to the emergency department, a nurse finds a foil packet in the resident's bed containing several pill fragments and a powder which appears to be crushed pills. So this is a pretty scary turn of events. This is fairly common in individuals who have their opioid abruptly discontinued or aggressively tapered. What happens is they go through withdrawal, and then they have a reduced tolerance, and then they attempt to go back and take their original dose, and they don't have the tolerance that they had before, so they end up overdosing. So this is why we have to be very careful about opioid prescribing and thinking about where people are in their dose, and thinking about screening individuals for opioid use disorder so we can provide them with the best support and care that we can. So risk of overdose in our population between 2000 and 2020, in individuals over 65, drug overdose deaths increased from 2.4 to 8.8 deaths per 100,000 standard population. So we had an increase in overdose deaths in individuals 65 and over. And age-adjusted rate of drug overdose deaths involving synthetic opioids other than methadone. So we're talking about fentanyl, and I think we all are kind of familiar about what's going on around fentanyl. Overdose deaths around fentanyl for adults aged over 65 increased by 53% between 2019 and 2020. So that's a fairly large amount. So we know that individuals over 65 are having increased amounts of overdose deaths. And you can see here, this is the curve from the CDC, the graph from the CDC, which is showing age-adjusted drug overdose deaths and for individuals over 65. And you can see it's going up. Again, this kind of breaks down the drug overdose deaths rates. This is only to demonstrate that individuals over 65 are having increased drug overdose deaths. That is why we have to be really cognizant of all of these statistics, because that's primarily the population that we're seeing in long-term care facilities. So there is always a potential, that we're going to be having an individual who experiences an overdose in our facilities. So that's why we have to be very careful about opioid prescribing. Definition of opioid use disorder. This is really important to know, and I'm sure a lot of people say, I know it, I know it, I know it. But you may really not, you may not be thinking about it in a way of brain circuits. So I really love this definition from the American Psychiatric Association. It says an important characteristic of substance use disorder is an underlying change in brain circuits that may persist beyond detoxification. That means if an individual comes off of an opioid, if they have an opioid use disorder, they come off of an opioid and they're not taking the opioid anymore, they still have the brain changes that make them have an opioid use disorder. So those changes remain. And so that's why individuals may have relapses and they continue to have intense drug cravings. And so when they are exposed to drug-related stimuli, this might be the impetus. So you might have an individual who was out in the community, had a diagnosis of opioid use disorder, and then stopped taking opioids, just is not taking opioids. They might have a hospitalization, get admitted to the skilled nursing facility, and then all around them are individuals taking opioids for pain. And so, that's the stimulus. These individuals still have those brain changes that make them have that diagnosis. So we have to be really, really cautious of individuals and again, do some screening so we understand what we're facing. Opioid use disorder, this is the diagnostic criteria. And as you can see, we could screen individuals in our own facilities. This is fairly easy. It's available at the CDC website. Opioid use disorder is manifested by at least 2 of the 11 criteria. It's important to know, though, tolerance and withdrawal is not considered to be met if individuals are taking opioids solely under appropriate medical supervision. So this screening talks about tolerance and withdrawal. So if you're taking opioids long-term, you're certainly going to have tolerance and withdrawal. That's just what happens when you take opioids. So opioid use disorder in older adults. A very small number of older adults are actually diagnosed with opioid use disorder, but that number of individuals who are being diagnosed is rising. It tripled. The number of individuals who are diagnosed with opioid use disorder, older adults, tripled from 2015 to 2018. They looked at a study of individuals over 50 prescribed opioids for chronic pain, and up to 35% admitted to misusing their prescription. So it's a big risk factor for opioid use disorder. And among adults over the age of 55, opioids have been found to be the primary substance of use in 20% of addiction treatment admissions. So it's becoming a bigger issue with time. If we look at opioid use disorder among hospitalized older adults, this was a study of over 7 million Medicare beneficiaries who had a inpatient hospitalization in 2016. So just any hospital admission, 75,000 had a diagnosis of opioid use disorder listed. And individuals who had an opioid use disorder were twice as likely to have a liver disease, had a longer length of stay, and were more likely to be readmitted to the hospital within 30 days. And 26.4 of beneficiaries with opioid use disorder were discharged to a skilled nursing facility. So this was in 2016. So you can imagine, as we're increasing in individuals getting diagnosed with opioid use disorder, we're going to have more and more individuals needing stays in post-acute care, long-term skilled nursing facilities. So when we think about opioid use disorder, a lot of the diagnosis and the consideration and the criteria really just kind of look at the broad population, but we really need to look at it the lens for older adults with our patient population. Cognitive impairment can prevent adequate self-monitoring. So an individual may be taking more than they realize, more opioids than they realize. Older adults may not understand that the use is hazardous. They might take more than, again, than they realize. They may not realize that some of their problems are from substance use. They may not realize that their problems with impairment, they might be falling asleep. They might be having falls. They don't realize that maybe some of their problems, difficulties are due to substance use. Older adults may have fewer activities, so it's really difficult to utilize that criteria of social withdrawal as a regular criteria. And consequences can occur from using smaller amounts in older adults because they have increased sensitivity to substances as they get older. And withdrawal symptoms can be very, very different. Late onset substance users may not develop psychological dependence. So it's really important to kind of take that into consideration when you are screening individuals for opioid use disorder in your facilities. So when we think about chronic opioid use, it's typically defined as 3 months or longer. So you're taking an opioid 3 months or longer. And opioid use is defined as taking an opioid in a way other than is prescribed, taking another the person's medication, taking the medication just to get high, not for pain relief. And opioid use disorder is defined as use of opioids that cause significant distress or impairment. So if you're seeing this in a resident in your facility, you really have to bring it to the attention of the physicians. They can do a screening, or you can do a screening in order to get the resident the best care. Just a little, some definitions. I think it's really important. We talk about withdrawal and tolerance. These things happen when an opioid is taken chronically. That means with tolerance, an individual requires increased doses over time. That's typical for opioids. That is pretty much how they work. And then withdrawal, that occurs when blood levels are reduced after chronic use. Diversion, I'm sure you're all familiar with diversion, but that occurs when there's the illicit transfer of a controlled substance from the legal distribution. So basically, just from the start of the legal distribution to dispensing channels, and when anything kind of goes awry. And then addiction to chronic disease is something that we really need to think about. I think that there's still a feeling that individuals who have opioid use disorder are making a choice. We know that this is a chronic disease. We know that it needs to be treated, and treatment is available. And if we educate ourselves and educate our staff to understand that this is a disease, then we can reduce stigma. And when we reduce stigma, individuals are more likely to access treatment. So it's really important that we kind of normalize this as a chronic disease that needs to be treated like any other chronic disease. Now, I want to highlight this text. This is based on a text that I received when I was on call on a weekend for multiple long-term care facilities. And so you might communicate with your physician or providers in your facilities similarly. And I would encourage you to rethink in the way that you communicate about opioids and really everything, because this text kind of puts a physician in a difficult situation. And, it puts the resident in a difficult situation. It puts everybody in a difficult situation. So the text is resident in 2201 has bad arthritis and has 150 milligram tramadol twice daily for pain. So tramadol is our opioid. States will not take only one. Resident wants 3. So 150 milligram total dose in the morning, and 2, which is 100 milligram at night. So we have the original order is 50 milligrams twice daily, and the dose escalation request is more than twice that. Otherwise, won't take it. And wants the order changed to hydrocodone, which is another opioid. What would you like me to do with the order? Resident just had left transmetatarsal amputation. So you can understand this is virtually impossible to respond to this text with an order medically appropriately. Like you can't just say, okay, increase that tramadol dose. That's not appropriate. Resident might overdose. I mean, that's too much of a dose escalation. And now the resident wants hydrocodone, and we don't know when the surgery happened. And so there really needs to be a lot more information to make sure that opioids are prescribed appropriately, that the resident's pain is treated appropriately. So I would not respond to this text. I would just call, because there's a lot more information that needs to be obtained. But you can imagine if there is a physician who just responds to this text and just says, okay, to increase the tramadol, we're starting at a dose escalation for this resident, which may not be appropriate. And we may then be kind of adding to this resident's risk of developing an opioid use disorder. And we don't want to do that. So that's why we have to be very cautious about our prescribing. We have this tool available on our website. This is where you can download it. It's really wonderful. You can do this on admission, readmission. You can do it at any time. You can do it for every resident in your facility. I would encourage it because it gives the physician a really good idea about who is at risk of developing opioid use disorder. There's been a really big push in the outpatient setting to kind of rein in opioid prescribing. I'll say I have a podcast. I'm very lucky to have a podcast in as part of my work here at Quality Insights. And I've talked to many individuals who are in recovery themselves and working as peer recovery experts. And the one thing that I have found, I've heard from them in their recovery journey, is that they were not aware of their risk of developing opioid use disorder when they were placed on opioids, that education was not done. So it's very important we do this, because we may be creating individuals who have opioid use disorder and then discharging them to the community. And then these individuals have an opioid use disorder in the community. So we really want to make sure we don't do that, or try to reduce that risk as much as possible. And some guidance associated with the screening tool: if an individual is low risk, moderate risk, high risk. If an individual is at high risk of developing opioid use, you want to avoid prescribing opioids if at all possible. You want to communicate with the resident. You want to offer support services. If you do have to prescribe opioids, you limit to a few days and monitor behaviors closely. I will say what's really great is with this tool, there may be residents, and I'm sure you have residents who are very anxious about pain pills. They don't want to get addicted to pain pills, but those residents may benefit from a very short course of opioid because they're having acute pain. And opioids are very useful for acute pain. So treating their acute pain with opioids for a short period of time, tapering the opioids off, may actually benefit them, because then they can do therapy and then they can possibly transition home, rather than having them kind of just tolerate pain for a period of time. It's really important to inform residents and families. So we are planning for safe and effective pain management, letting families and residents know. A family might think their loved one is at risk of developing opioid use disorder, and they're at low risk. So, it's important to communicate that. Or they might think the resident doesn't have a risk at all, and the resident might be high risk. So it's important to communicate these things. And then to discuss with residents who have a risk of opioid use disorder that safeguards will be used. And then, the resident might say, I really appreciate that you're doing this, because I wasn't aware that I was at a high risk of developing opioid use disorder, and I don't want that. So we really empower our residents by using these tools. So another case, a 44-year-old male is admitted to the facility after a hospitalization for lumbar laminectomy infusion. He is ordered oxycodone 5 milligrams every 6 hours as needed for pain in the hospital, but this medication is stopped prior to discharge to the SNF. So something to kind of ask yourself, why was a pain medication stopped? He arrives and asks for something stronger than oxycodone 5s. He states his pain is 105 out of 10. I've seen cases like this many, many times, when the nurse calls me to verify the medications and says, it says on the discharge medications that the oxycodone was stopped in the hospital, but the resident is asking for it. Can you just call in a script? Like, that's not appropriate. We need to kind of find out what type of pain, why the oxycodone was stopped. Is this resident at high risk of developing opioid use disorder? Because these medications are far from benign. They are really, have a lot of adverse effects. So we have to be very, very cautious. So as you can see, the medications that this resident is receiving, cyclobenzaprine is a muscle relaxant, so he's receiving that, and gabapentin, possibly for neuropathic pain. So in this case, we want to perform a thorough history and physical, make sure we understand the diagnosis for quetiapine, which is an antipsychotic. We really have to make sure we understand why the resident is receiving an antipsychotic. Utilize an opioid risk assessment tool. Look at the resident's risk of developing opioid use disorder, and then utilize that tool along with your findings in the history and physical, type of pain, history of opioid use, all of these kinds of things. And then consider non-opioid option if the individual is moderate to high risk for opioid use disorder. If you let the resident know you are at high risk of developing opioid use disorder, I would really like to explore other options with you to keep you safe. I think that is so wonderful to communicate very clearly with a resident. Use a multimodal approach in pain management. There's many things available in pill form, non-pill form for pain, and then communicate the findings and plan with the resident. Another case, 84-year-old female is admitted to the facility after hospitalization for a femur fracture and repair. She is ordered hydrocodone acetaminophen 5/325 every 4 hours PRN in the hospital, but it was discontinued prior to discharge. She states she's in excruciating pain, but she doesn't want to get hooked on pain pills. So here we have a resident who is anxious about taking an opioid and only receiving here acetaminophen, which is Tylenol, for pain, but in excruciating pain. And because there's been a recent fracture, which is acute pain, which is appropriate to treat acute pain with an opioid for short term. That is appropriate. That is an appropriate way to utilize opioids. So we perform a thorough history and physical. We utilize the risk assessment tool and consider non-opioid options if this individual is moderate to high risk. If this individual is low risk, we communicate these findings with her. We say, you are at low risk of developing opioid use disorder per our verified screening tool. And therefore, we feel confident that a short course of opioids might help you get through this pain, do really well in your physical therapy, and then transition home. Always use a multimodal approach. You're layering on your pain, your options for pain. So we can cover, make sure we maximize pain relief, and then communicate the findings and plan with the resident. Always important. I don't know how many residents and patients I've talked to who have no idea what's going on. And that fear of being kind of out of control with your own care has been shown to make pain worse. So communicating with a resident, really being cognizant of what words we're using is a really powerful thing, and make residents feel like they're safe in their care, and then they can have increased pain relief. So how can we reduce risk of long-term opioid use and opioid use disorder? Shorter day supply, lower daily dose, and not prescribing opioids to individuals at risk of opioid use disorder. So really important. If we're just screening, so the previous screening tool is for screening for individuals who are at risk of developing opioid use disorder. If we have an individual who has a diagnosis of opioid use disorder, we can use the drug abuse screening tool, which is the DAS-28, DAS-10, and this gives zones of use. It also gives some indicated actions. We also have the tobacco, alcohol, prescription medications, and other substance. This is called TAPS. It has two components. The first component is a 4-item screen for tobacco, alcohol, illicit drugs, and non-medical use of prescription drugs. If an individual screens positive on the TAPS 1, then you start the TAPS 2. If you're going all in, if you're saying we're going to do a screening for opioid use disorder risk, we're also going to screen for opioid use disorder as well as other substances, then these tools are available. And on this slide, it kind of says where they're available for free, and you can use all of these tools. If you want a list of the tools, again, it's on the same site, the screening and assessment tools chart. You can kind of find what you're looking for. You're looking for adult screening, obviously. You want to look at a clinician administered chart tool if you're going to use it in the facility. If you're looking for alcohol or drugs or both, so you can find all screening available on this website. Easy to use. And that is it for part 1. Any questions?
All right, thank you, Dr. Storm. We don't have any questions so far, so while we wait, I'm going to run over some closing notes. If you do have a question, please submit it using either the chat or the Q&A tool in your Zoom menu. And you could also raise your hand if you'd like to ask your question out loud. I'd again like to invite everyone to next week's webinar, which, as you know, is going to be part 2 of today's discussion, and that will be next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on anything from quality improvement initiatives to infection control or MDS coding. You can find the links to our live chats and webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org, and I will get you on that list. Now, Dr. Storm has her contact information up there. I'm going to drop mine in the chat and along with Dr. Storm's. And it looks like we don't have any questions. Dr. Storm, are there any closing items you'd like to say before we get ready to wrap up?
If anyone has any questions that you'd rather not ask in this forum, I understand. You can feel free to email me. Plenty of facilities do that after the webinars, and I am happy to address them one-on-one.
Thank you, Dr. Storm. All right, in that case, I will go ahead and wrap us up. I dropped the link to that opioid risk assessment tool in the chat, but I'll be emailing everybody here later this week with a link to the recording and a link to the presentation slides, and you'll be able to get the tool there if you would like to access it. All right, in that case, I will go ahead and wrap this up. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Jean, I would like to thank you for joining us again this week. And I'd like to thank all of you for joining us and hope to see you back here again soon.